Hello, everyone, and welcome to the Parkinson's Foundation program, Beyond the Diagnosis, Managing Changing Symptoms. I'm Sarah Maldonado, Community Program Manager for the Parkinson's Foundation in the Southwest chapter, and I'm excited to be here with you today to bring you this educational program. I'd love to take a second and hear from our audience. Let us know in the chat where you are joining us from today. I'm based here in Phoenix, Arizona, but I know we have people joining us from all over the Southwest, so we would love to hear from you. We'll give everyone a couple seconds to write in the chat. Thank you to those of you who have shared. We hope you know that you are not alone. And as you can see from the chat, your Parkinson's community is here with you from near and far. For those of you who are new to the Parkinson's Foundation, welcome. We are the nation's leading community for people with Parkinson's disease, the people who love them, and all of those who are working to end the disease. With our presence in communities across the country and the globe, we believe in the promise of a cure and a better life for those impacted by PD. The urgency of our mission really translates into what we do. To achieve our mission, we pursue three goals: ensuring better care for everyone with Parkinson's, advancing research towards a cure, and educating and empowering the Parkinson's community. We provide free resources, including our website, parkinson.org, educational book series, webinars, podcasts, a hospital safety kit called Aware and Care, our newly diagnosed materials, and of course, our toll-free helpline at 1-800-4PD-INFO. On the research front, we invest more than $10 million annually to study Parkinson's, what causes it, how to treat it, and ultimately how to cure it. I'd like to highlight PD Generation, which is a Parkinson's Foundation initiative that offers genetic testing and genetic counseling at no cost for people with Parkinson's. Participation can be done in person at the Muhammad Ali Parkinson Center in Phoenix, Arizona, or from home through a telemedicine appointment and an at-home cheek swab collection kit. You can contact me or click the link in the chat to learn more. We also want to highlight a study that you can participate in from home. The TOPAZ study will test if a medicine can prevent fractures in those older than 60 living with Parkinson's disease. If you qualify, a nurse will come to your home and you'll receive a one-time treatment. You can call our helpline at 1-800-4PD-INFO to learn more. Before we begin, I'd like to give a huge thank you to our gold sponsors, AbbVie, Acadia, and Boston Scientific. Thank you so much for your support. All right, let's jump into today's topic, Beyond the Diagnosis. I would like to introduce our speaker, Dr. Sherman. Dr. Scott Sherman is an associate professor of neurology and the director of the Movement Disorders program at the University of Arizona. Dr. Sherman's research interests include deep brain stimulation, gene therapy, and cell-based therapy for Parkinson's disease. More immediate goals are repurposing existing therapeutics for application to Parkinson's disease, particularly for cognitive problems and dyskinesia. He divides his time between patient care, basic research, and conducting clinical trials. He has been awarded for outstanding achievement in teaching and outstanding progress in research by the University of Arizona College of Medicine. Thank you so much for joining us today, Dr. Sherman. I will pass it off to you and you can go ahead and share your screen.
Okay, hello. Well, it's really, thank you so much for the opportunity to speak to this group, I guess regional. Of course, I was really looking forward to seeing people with Parkinson's in person, and I hope that we can get back to that soon, but this is a great opportunity as well. What I'd like to do is go over some basic information that applies to people with Parkinson's. I'd like to start talking a little bit about the basics of Parkinson's and then delve into some of the available treatments and how those might apply to people that are mid-stride in the Parkinson's disease. And then a little bit, if time permitting, go through some of the research that we're doing both clinically here locally in Tucson, Arizona, but some research that's going to be available nationwide very soon. And also talk a little bit about some of our laboratory research that's very much in the future, but give folks a little bit of an idea of some of the things that are being done on the scientific front, at least here in Tucson and elsewhere, to really delve into finding new treatments for Parkinson's disease. Well, of course, it's important to know what causes Parkinson's disease. And I know that the Parkinson's Foundation has been involved in supporting a lot of this research. And that's really the basis of maybe coming up with new therapies and eventually cures for Parkinson's disease. What we do know so far is that Parkinson's disease is a neurodegenerative disorder that affects mostly the dopamine containing neurons in the brain in a specific area called the substantia nigra. That's here in the base of the brain, or the midbrain. And then here in the blow up in this slide, we see a picture of a synapse, which I'll show you some actual pictures of the synapse a little bit later in the course of this talk, if we can get to that. But of course, this is where dopamine is released from nerve endings, and where it's received by the dopamine receptor, and where many drugs act at the dopamine receptor. So we know that there is damage to these dopaminergic neurons. Of course, the damage is not just confined to these dopamine cells, but we're learning that it may affect other parts of the brain as well. But this is certainly where a lot of the difficulty can occur in the brain coping with Parkinson's disease, and where a lot of our medications are aimed. We know that about 10 to 15% of Parkinson's has maybe what we say a purely genetic cause. In other words, there would be a single gene that is present that runs in the family that would cause Parkinson's disease with varying degrees of certainties. You know, some very unusual genes may cause Parkinson's in the majority of patients that haven't inherited that gene. However, most of Parkinson's that we see is some complicated interaction between multiple different genes that are inherited, and some factors that occur in the environment. And we are still figuring out what all of those environmental exposures may be, but they would include something like head trauma, which could occur many, many years before the development of Parkinson's. Another environmental exposure, for example, maybe exposure to heavy metals or certain pesticides that are in the environment that we know are a risk factor for later developing Parkinson's. And of course, there may be some environmental factors that help prevent Parkinson's too. For example, exposure to caffeine and exposure to nicotine may be somewhat allowing some resistance to Parkinson's disease. Perhaps exercise might be considered an environmental factor in a certain way that helps prevent Parkinson's disease. So we have a lot of work to do to sort out exactly how these interactions occur. It is a big problem, and we certainly need more research and more people to be aware of the extent of Parkinson's disease. So there's over 1 million Americans that have Parkinson's disease, over 10 million people worldwide. And I think it would be safe to say that really people with Parkinson's are definitely not alone. As people are aging more successfully, Parkinson's is becoming much more prevalent. We figure 1% of people over the age 55 have Parkinson's, and that goes up with every decade. So it's really the second most common neurodegenerative disorder, really sort of something that we need to grapple with, and something that I think we need to advocate for more resources and research to deal with Parkinson's disease. Well, I'm going to show you, we're going to start at some basics, and I'm going to show you at different levels what happens in Parkinson's disease. And here we have the slice of someone that has donated their brain. And after that they're done with it. And then we can look at this in the actual section. This is a part of the midbrain. And in a healthy person or someone without Parkinson's disease, this sample probably came from a young person. We can see that there's a couple areas in the brain that are pretty much the only colored areas in the brain are of any interest in looking at an actual cadaver brain slice like we look at with medical students in our anatomy lab in their first year. It's good to point this out. And so there is this black stripe of substance, which in order to make it fancy in Latin, we call this substantia nigra. That just means black stuff. And then there's this area called the red nucleus. We can see that this black stuff becomes damaged or diminished in people that have developed Parkinson's during their lifetime. And the reason that this area is black is because it contains a substance called neuromelanin. And if we drill down and look at these cells, we can see that younger in life or in people that have no signs of Parkinson's, there's lots of these brown staining cells that contain this pigment neuromelanin. But that in Parkinson's disease, as it becomes more severe, there's an obvious loss of these brown cells. And then if we can drill down even at a closer level and look at one of these cells that comes from a person that had Parkinson's, we see that not only is there this neuropigment indicating it's one of these dopamine cells, but there is this round circular object, which is called a Lewy body. And the Lewy body is made up of damaged proteins, particularly a protein called alpha-synuclein that is the focus of a lot of research. We think that Parkinson's may start with damage to this particular protein, alpha-synuclein, and that as that damage accumulates, the cell may try to sequester this away, but this becomes what's called a Lewy body when seen under the microscope. And this has been known, of course, for many decades and put us on the track to really kind of studying what the molecular basis of Parkinson's is. Well, we can't look for Lewy bodies in a living patient. That is something that we need to have a brain donated or something that we look at in the laboratory. However, there are ways of looking at the same damage in living patients or people with Parkinson's. And these are nuclear medicine scans. Right now, a type of scan that the company GE produces that's trademarked as a DAT scan. Technically, an ioflupane nuclear medicine scan is available. And in young people, we can see that there is a very bright red color that occurs that is marking where cells are healthy and releasing dopamine. Even early in Parkinson's disease, we can see that there's some loss of these cells. Some people may notice that the background color of the brain changes. The eyes would be here. This is the back of the head. This is a slice at the level of the top of the ear that goes through. And here's loads of these dopamine producing cells. And even when the symptoms are barely detectable by the person with Parkinson's or by the physician, we can see that there's already been enough damage done to these cells that we can detect this by a DAT scan. Right now, this scan is only used for diagnosis by the FDA of Parkinson's. So someone may have a type of tremor. We don't know if it's Parkinson's or not, or we may be suspicious of Parkinson's disease. A doctor would order the scan, and right now it could confirm the presence or absence of Parkinson's disease. However, in the future, we could see that this type of scan, if it was repeated, may tell us something about the rate of progression of Parkinson's disease. And so that in advancing Parkinson's disease, we can see there's even a greater loss of these neurons. So for initial diagnosis right now, it's important. People that already know they have Parkinson's disease and are under care for it, this is not something that every doctor would necessarily order, but in the future, it may play a role in sort of staging where the Parkinson's disease is. And it certainly may play a role in research as we start to have treatments that can slow the progression of Parkinson's. Well, what are the symptoms of Parkinson's disease? From a technical standpoint, in order to make the diagnosis, we look for 3 of the so-called cardinal symptoms of Parkinson's disease. These are tremor, rigidity, also known as stiffness, and bradykinesia, which in regular language terms would be slowness of movement. And bradykinesia can also be manifest by shuffling, and some other maybe changes in facial expression would be examples of bradykinesia. And we know that there's an important 4th cardinal symptom as well that some patients get, which is postural instability or problems with balance. So in this category are what we call the motor symptoms that are necessary for the diagnosis and an important set of symptoms to treat. Increasingly, we know that there are a set of symptoms that we refer to as non-motor symptoms that are important to treat as well. And here are just a few of these, certainly not all of them, but they can include a decreased sense of smell. Of course, in this era of COVID, it's sometimes hard to ask people when there was a change in sense of smell, since so many people have had that altered. The decreased sense of smell can be an early symptom of Parkinson's disease. So can depression or mood problems, insomnia, bladder and bowel dysfunction can occur in Parkinson's. These are a couple items that I think we don't know so well how to treat, and perhaps are not discussed as much as they ought to be. And that is fatigue, which can really be overwhelming in Parkinson's, and can occur even when patients are sleeping well. There can still be an element of fatigue, and also pain. Sometimes I've gotten the impression that people think that Parkinson's is not painful, or I've heard it said that, well, at least it's not painful, but that's not true, because there can be a number of sources of pain that can occur in Parkinson's disease, and that is a whole lecture even unto itself. Well, let's talk for just a moment about some of the stages of Parkinson's disease. Stage 1 occurs when Parkinson's is just on one side of the body. Stage 2, if it affects both sides. Stage 3, where there's both sides of the body and a loss of balance. Stage 4, the symptoms become more limiting. And we're going to kind of discuss these mid stages here of Parkinson's. But there is another way to look at the progression of Parkinson's disease, of what's happening in the brain, and it's more difficult for us to look at this in real time. But we think that Parkinson's may actually start in the lower brain regions. It's certainly the first system that is affected. And here we have challenges that can occur in the so-called automatic or autonomic nervous system that we'll go over. The Parkinson's may then progress to include this part of the upper brainstem where depression and sleep disorders can occur. Later, there can be progression to include the substantia nigra, where the dopamine system has its base. And then eventually, in some patients, this may move on to certain areas of the cortex part of the brain where it can affect memory and concentration. So things don't always occur in this order, but from a research standpoint, this scheme by the neurophysiologist and pathologist Brock and Brock, husband and wife team, is still very useful for us, though we can't see this in real time. And it does suggest that maybe there's something that starts somewhere in one part of the body that can spread from area to area, although the research is not completely clear about that. Well, let's jump into some treatments for some common symptoms of Parkinson's disease and some of the common medications that are used. Of course, carbidopa-levodopa is a main choice that's used for treating the motor symptoms, and a number of other medications, a long list that can be chosen by the physician. And we'll kind of go through these maybe in a little bit more detail. And of course, there's a number of brands that are associated with these, but many of these have generic versions too. And sometimes we talk about Cinemet because it's so much in the literature, but that's really a brand name for carbidopa, levodopa, which is usually prescribed. Well, what are the potential goals of treatment? There's a few things that we can think of that your physician and you might have in mind when plotting a therapeutic course. So first of all, there would be improvement in the movement symptoms, the tremor, slowness, and stiffness. Those can all be controlled with medications and other therapeutic treatments. But also control of the non-movement symptoms is important as well. And then of course, the holy grail of Parkinson's research really is we want to achieve what we call as disease modification. Another word for that might be neuroprotection. But many people I talk to, if we could only control their Parkinson's in the stage that it's at, and if it never got any worse, it would be very livable. But we don't have those therapies that are available now. I feel like we're on the edge of developing these therapies, but really we would like to have some type of neuroprotection or some treatment that prevents the disease from moving to other stages. One thing that we can think of right now is exercise is one thing that does have some demonstrated neuroprotection, and most communities have a Parkinson's specific exercise group, but whatever type of exercise people like to do is useful, and there aren't specific recommendations for the exact type of exercise, probably some mix of aerobic and other exercises that help balance. But one thing, sometimes people want to say, well, I just want to exercise. I don't want to take medications. And well, one thing to keep in mind is that optimum symptom control with the available medications can improve exercise capacity. So while the medicines we have right now do not really modify Parkinson's disease directly, by helping stay active, they can have this indirect goal. And I think that's an important thing to think about. Well, let's talk about levodopa, which is the most important treatment in the medications for Parkinson's disease. And the thing about levodopa is that it does not get into the brain. Is that we can't use dopamine because that would not get into the brain directly. When we take a medication, it has to go from the body, what we call the peripheral part of the system, which is the stomach and the bloodstream. It has to make its way into the brain, and dopamine cannot cross into the brain. So just giving patients dopamine doesn't work. But of course, decades ago, an important discovery was that the precursor levodopa does cross the blood-brain barrier and get in the brain. So we use levodopa a lot for treating Parkinson's. While levodopa is out here in the peripheral compartment in the bloodstream though, one thing is that we do know that it's susceptible to breakdown. And if it breaks down in the bloodstream or in the gut, it's not available to cross the blood-brain barrier. So this slide shows that dopamine itself cannot cross, but levodopa can, but we need to protect it when it's out here in the periphery. So carbidopa prevents levodopa from being converted to dopamine prematurely. We want it to go into the brain and get converted to dopamine. So virtually all levodopa has carbidopa with it. If not, it doesn't last very long in the periphery. The one exception to this is Inbrija, which is an inhaled form of levodopa that gets directly into the lungs and directly into the bloodstream. But even then, it only works if the patients are also taking carbidopa in some other form, or it would break down too quickly. The other way of preventing the breakdown are a couple of adjunct medications. The most commonly used one is called entacapone, and that prevents the breakdown of levodopa from another enzyme in the periphery. So almost always carbidopa is used. Entacapone, atolcapone, opicapone are some options that are used as add-on treatments that help drive levodopa into the brain. these enhance levodopa about 15 to 30% in most patients. They're not as important as the carbidopa, but can be a treatment option. Well, levodopa works so well. The question comes up, really, why do we need anything else other than levodopa? And the issue is that over time, some things happen that makes levodopa alone an imperfect treatment. And one way to explain this has to do with motor fluctuations and with what I call the therapeutic index. And this slide kind of demonstrates over time what can happen. So in early Parkinson's disease, when you take a pill of levodopa and it kicks in, the blood level goes up, it reaches a peak, it comes back down, but it stays within the so-called therapeutic window. And so someone can take levodopa 3 or 4 times a day. It doesn't have to be very frequent. And the brain is storing the levodopa and releasing it. And so it stays within this therapeutic window. As Parkinson's becomes more moderate, though, it's necessary to take the levodopa more frequently, as shown by these levodopa tablets here. And the reason for that is that the therapeutic window becomes less. And so now the blood level is going up and down. And when it gets a little bit too high, symptoms of too much levodopa can occur, particularly a symptom called dyskinesia, which is movements that are uncontrollable or involuntary movements that can occur in the head or the limbs. And those can occur in moderate to advanced Parkinson's. But the main thing also is off time, so that in between doses, the level's getting so low that the medication is wearing off. And so this becomes a mid-stride challenge in dealing with Parkinson's, is making sure that these off times are not impacting quality of life, because they can. And if people are spending 2 or 3 hours per day in off time, then that is time that they're not at their peak and not functioning their peak. And so that we really should try therapies to minimize these motor fluctuations. So that's really why we end up using medications other than levodopa. Now the order, so this is a slide I call the continuum of treatment, and it's really going from, in some ways, like more simple treatments to more complicated ones, or we can think of it as milder treatments to treatments that are more stronger for treating the symptoms. And we notice that levodopa is right in the center of this. Of course, whether we start with levodopa or not is a question that has to be individualized for each patient. Years ago, we had thought that we should stick to this strict order of medications. It was kind of along the lines of how we treat diabetes or high blood pressure, always starting with the mildest agent and sort of adding that on. And people were concerned that starting levodopa too early could lead to these side effects. Now we know now that that's not the case, and that starting with levodopa is a good option. But of course, for people that are mid-stride in the Parkinson's, they're going to be likely taking levodopa. And they may or may not have been on these other medications. And so adding these can be useful. These are the MAO inhibitors that I'll go over, the dopamine agonists, some ancillary medications. And then when medications are no longer controlling the symptoms, for some patients, deep brain stimulation could be an option. So what are the MAOB inhibitors? The standard one is selegiline. This comes usually as 5 milligrams that can be taken twice daily. It's inexpensive. It has few side effects. Some of the active metabolites may help with fatigue. What are some of the problems with selegiline? Well, one thing is that it seems to have a lot of drug-drug interactions that mostly these days are a problem because they pop up on your physician's computer screen. And having someone familiar with Parkinson's can be useful because a lot of these drug-drug interactions we can okay that and know that it's okay to use them with caution. Particularly selegiline and antidepressants often trigger some warning of a drug-drug interaction, and often it's safe to take those together. Another MAOB inhibitor is rasagiline, brand name is Azilect. Now, there's been some evidence that this drug may have some neuroprotection. A lot of studies were carried out thinking that rasagiline may help modify disease. They never really came to a conclusion, and that research is decades old. And since this is generic now and there's not a patent, there's not been the motivation really to go back and put more effort into this. Probably we think that there's better neuroprotective agents, but it is something to keep in mind that there's an open question on this drug and really the whole class, if they may be useful for long-term protection from Parkinson's. The latest addition to this group is safinamide or Zadago. It's a newer drug. It may be expensive, and I have not had that much personal experience with prescribing it. So maybe we can hear if any patients have had found that useful. The dopamine agonists, of course, have been around for a long time, and they can be quite useful. The medications that are taken orally are pramipexole, branded Mirapex or ropinirole. We have a couple of injectable and now a sublingual dopamine agonist that's called apomorphine. And then transdermal skin patch is rotigotine, or Nupro skin patch. So these are medications that are called the dopamine agonists, and they can help treat this wearing off period and limit dependence on levodopa alone. So what are some of the advantages of dopamine agonists that we would want to consider those as part of the mix in treating Parkinson's disease? Well, one thing is that they have a long duration of effect, so they can be given 3 times a day. Unlike levodopa that has to be given more frequently, that can be a benefit. They can allow a reduction of the amount of levodopa that would ultimately need to be used and can take the edges off that fluctuation and help reduce off time. These medications, when given alone, do not cause dyskinesia, and so that is important. And some people have advocated starting them before levodopa for this reason, but at any point they can help reduce dyskinesia. Sometimes it's easier to do that before the dyskinesia occurs. This group of medications can improve sleep, and they may have some intrinsic antidepressant activity that can be useful even without having to take an antidepressant. Of course, there are some disadvantages to this group of medications, which these side effects can occur with any Parkinson's medicine, but in this group of dopamine agonists, we need to be particularly on the lookout for some of these issues, particularly sleep attacks, as something different from drowsiness is something that we know now can occur with this. Sometimes people aren't feeling drowsy, but they may be at a stoplight and fall asleep while in the car, or find if they're watching TV or reading a book that they want to stay awake, but they sort of can't fend off falling asleep, even though it doesn't really cause drowsiness per se. And so that's something to be aware of. They lower blood pressure, and they can cause some leg swelling. And some of these medications have been associated with compulsive behaviors such as eating, gambling, and sex addiction. And so it's important to be aware of this particular set of side effects. People may think not attributed to use of the medication. And so I think physicians are more aware of this set of symptoms, and we can be on the lookout for it. Not a reason to totally avoid this group of drugs, but just something to be aware of as a potential side effect. Now, we talked about in this scheme in which Parkinson's can affect different parts of the brain. When it affects the low brainstem, which can occur in Parkinson's, is low blood pressure can be a problem. I mean, most of us in this country have a problem with high blood pressure, but low blood pressure can really be an issue with Parkinson's. And so there's a few medications that I want to mention that are used to treat low blood pressure. Now, one of these is fludrocortisone, which is given once a day, and that can help raise blood pressure. Its disadvantage is sometimes it can cause some swelling in the legs, but its advantage is it's just once a day. Midodrine is another medication that can help restore blood pressure back to normal. It needs to be taken 2 or 3 times a day, and that's a disadvantage of it. Sometimes you can overshoot with midodrine too, as another disadvantage, but we're very glad to have this set of drugs because having low blood pressure is important to treat. It can contribute to fatigue, and in and of itself, it can lead to symptoms of dizziness and weakness and even passing out if it gets too low. So this needs to be treated. Another medication to use low blood pressure is a relative newcomer called droxidopa. There's a study called Restore that's in progress, I think all over the country. I know we're recruiting now here in Arizona, which is looking for the more long-term safety of droxidopa, but your physician can prescribe this now. Other symptoms, constipation, bladder problems can occur with Parkinson's, and levodopa alone doesn't control these. So it's important to talk to a physician about other treatments that are targeting these. Excessive salivation is a symptom that occurs due to problems with the autonomic nervous system. And injection of botulinum toxins, Myoblock or Botox brands, whatever brand, can be very effective for excessive salivation. And so it's important to get the word out for that. That treatment can be done once every 3 months and can be very effective rather than having to take oral medications that can have other side effects. Changes in sweating and increased sweating can also occur in Parkinson's. And these are all symptoms that have to do with the autonomic nervous system. Sleep problems. Well, I think sleep problems are so common in Parkinson's and they can be difficult to address. They can occur in quite a few different forms. Insomnia can occur commonly in Parkinson's, and this can occur either as difficulty in falling asleep, but more commonly awakening too early. And that can lead to only sleeping 4 or 5 hours a night, which may not be enough. Excessive daytime sleepiness can occur due to the insomnia or by itself that needs treatment. In general, there can be disruption of normal sleep patterns. It can be difficult even to turn over in bed. There is an increased incidence of sleep apnea. I will say that while this should be investigated, very often people with Parkinson's will, quote, fail a sleep apnea test, but not need full treatment for sleep apnea. So it's good to be aware of this and also have someone with expertise in Parkinson's help navigate whether the sleep apnea needs treatment and what type of treatment. REM sleep behavior disorder, which can manifest itself by nightmares, fighting in sleep, sometimes getting out of bed, is very common. REM sleep behavior disorder is a symptom that occurs very early on in Parkinson's, but usually not recognized. We think it may even predate the ability of us to diagnose Parkinson's. I will point out there's a number of effective treatments for that. Clonazepam can be highly effective. This is a benzodiazepine class, and physicians may be hesitant to prescribe this class of medications, but it can be quite effective. And I know my colleagues and myself, we found that this can be useful. If patients take this every night, you don't want to stop it suddenly. There might be some rebound. And as far as getting through this disruption of normal sleep patterns, taking a nighttime dose of levodopa and maybe a long-acting form that can last all night can be very helpful because during sleep, it could be that you're not able to wake up time enough and the levodopa wears off. So a long-acting dose or making sure the levodopa lasts through the night can help avoid this disruption of normal sleep patterns. Even if we treat sleep and we've ruled out sleep apnea and looked into trying to get to sleep better, there can still be excessive daytime sleepiness. Caffeine can be useful for this. That seems obvious, but a lot of times people with Parkinson's, they don't drink caffeine or it may make their tremor worse, so it can be useful. Selegiline, as I mentioned, can help with this. And then we can sometimes use an actual stimulant medication. Modafinil is one medication that can be used. And one thing about modafinil is it does not decrease appetite. Using the standard stimulants like Ritalin or methylphenidate or amphetamines can be useful, but sometimes these can decrease appetite. And again, these medications, some physicians may be reticent to prescribe these because they're controlled medications, but I found that they sometimes are necessary and can be quite helpful in people with Parkinson's maintaining an active schedule. In terms of neuropsychiatric symptoms, many things can occur, most of them not till later in Parkinson's disease, but I will point out that depression is an important thing to keep in mind mid-stride. The majority of people with Parkinson's will at some point in living with Parkinson's experience depression. I mean, it's so common anyway in the general population. That depression is there, but we should be on particular guard for depression and Parkinson's, and standard antidepressant medications can help, and they rarely interfere with Parkinson's treatment, although there's warnings for that. I was asked to just talk to speak to a couple particular symptoms that can occur in Parkinson's disease. They have names that might not, that are medical, but we can talk about what they are. One thing is dystonia, and that's a fancy name for a muscle pulling or muscle cramp almost, or muscle contraction. And we hear a lot about certain types of dystonias that are genetic. Many of these are really not Parkinson's disease at all, but their own disorder. They have a different genetic basis. Some of them have some Parkinson's type symptoms with them. But what we want to talk about really is dystonia occurring as a symptom of Parkinson's disease. And most often this occurs in the calf or the foot, sometimes in the neck. And if these are really prominent, we need to consider, whether this is atypical Parkinson's, but even in typical Parkinson's that we're discussing, this can occur most often as a wearing off symptom. And so if this happens, adjusting the dopamine therapy can help, but dystonia can be a little bit tricky. Sometimes more Parkinson's medications or turning up DBS can help the dystonia, and sometimes it can be a cause of it. Dystonia is often treated with Botox when it occurs outside of PD. We can use botulinum toxin in Parkinson's disease, but it has to be done very carefully. It's a little tricky because we can make some Parkinson's symptoms worse. So I would say that dystonia, that's one of the areas that really getting some expert opinion about the treatment for that can be helpful. Freezing of gait is something that occurs most often in Parkinson's, rarely in other neurological conditions. And if people have seen someone this or you have it, you'll know what I'm talking about. It is kind of a peculiar phenomenon where someone's walking, comes up to a doorway or some other sensory threshold and just simply can't move. We really don't understand this phenomenon scientifically. One thing to keep in mind is that more levodopa or more dopamine therapy is not always helpful. This is one symptom that might have less to do with dopamine, more to do with some other brain chemicals like acetylcholine. But if freezing is occurring, oftentimes physical therapy can be of help. because cueing using some devices or some techniques like marching in place or singing, using a laser light, these are often very particular to each patient and they need to be customized to see what works. But freezing of gait is something that can occur sort of toward the end of the midsection of Parkinson's disease, but is an important symptom and one that needs some more research to know how we can treat this. Well, I don't want to focus on DBS too much since we were really talking about things that were happening mid-stride in Parkinson's disease, but I do want to mention that people sometimes think that DBS, which uses a pacemaker-like device and a wire that goes into the brain, sometimes we think of this as a treatment of last resort or something that only should be used in the end stages of Parkinson's. And I would like to point out that this therapy is not considered experimental. It's considered part of the therapeutic armamentarium. And when someone is at the point where medications alone are not allowing them to live their life to the fullest and impacting their activities of daily living due to wearing off or dyskinesia, this might be one option to consider. And this is widely available all over the country. Just a quick slide to show that that there's good data from now from 3 different companies that have devices on the market that can show that the percentage of time spent with good mobility after DBS increases quite a bit from before. So this is an important thing to keep in mind. Well, I'm just about out of time, and we did not get time to really talk about any of our research opportunities or some of that, maybe if there's some questions, but this would be a good time just to kind of highlight some of the treatments for Parkinson's disease and really point out that these are often used together. So it's not that we do one after the other, because exercise can be an effective treatment, and this should be done, at all stages of Parkinson's. Medications we talked about. Most patients at some point mid-stride in Parkinson's are going to be on levodopa, but we talked about some of the other medications. And we just sort of touched on deep brain stimulation a little bit. There are also other surgeries. We won't go into those in this talk. And then it is good to mention the rehabilitative therapies, physical therapy, occupational therapy, and speech therapy. And these, I think, are not used often enough. Insurance pays for them, and we should be sure to make full use of these. Particularly physical therapy can be very useful, even earlier on in Parkinson's in setting up an exercise program that is useful for each individual patient that can be followed. So the physical therapy may just last a brief period of time of a few weeks, but setting up a exercise program can be very useful. And then using rehab later on, I would recommend that people go ahead and use up their rehab benefits to take full advantage of the exercise option in Parkinson's. Okay, I will stop there. I'll just point out that our research is ongoing here, and perhaps we'll have another time to discuss that in another meeting, which I'd love to do.
Great, thank you, Dr. Sherman. And we can even talk about that in the Q&A if we have a couple of minutes at the end. So we'll be sure to share some of that information on the research. But thank you so much for that wonderful presentation. If anyone has any questions based on the information that you just heard, feel free to continue submitting your questions in the Q&A icon down below or in the chat. So speaking of exercise and the benefits of that, we're going to take a quick 10-minute exercise break. So as you just learned, there's clear evidence that exercise helps with both the motor and non-motor symptoms. Studies have shown that people with Parkinson's who exercise fall less often, have fewer falls resulting in injury, and exercise leads to improvement in flexibility, strength, and balance. So on that note, before we jump into our live Q&A, we're going to do a quick 10-minute movement break and do some seated cardio.
Today's fitness focus is cardio, which I'm going to show you how you can do in sitting this whole segment. Props that you'll need include a ball, or you can use a cushion, but you're really going to energize this with me. So I want you to sit nice and tall, come forward in your chair, and use the bottom of the chair or your armrest for support as we start to warm up those legs. I want you to take your left heel out and bring it in, and opposite side and bring it in. Keep going out and in, and try to lift that heel up and off the floor. Stay with me on this tempo. We're just warming it up. You'll notice we'll go into higher tempos and lower tempos. We're going to get the arms involved as well. Keep this going. You've got 3 more sets before we add the arm and opposite arm to the leg, reaching overhead. In 2, you've got this. 1 more time. Okay, so left leg, right arm up, and switch. Keep going. Kick out, arm up and in. You've got this. Try to move together. Opposite sides. Give me 5 more sets. Keep going. You've got 4 before we focus just on the arms, moving them big. Keep it up. You've got 2. Push up. Last time. And stop those feet. Sit tall. Arms are down. Think of an upside down V. And then I want you to flip it. Take it down and up, like you're chopping right through the air. Keep this going. Really exaggerate the stops and the starts of the motion. You've got 5 more. Keep this up. In 4. Nice work. Last 3. And up. And 2. And up. 1 more time. Up. Arms come down to the seat. Hips forward. Take 1 foot out and in. Other foot out and in. 2 more times at this pace. 1 more set, and then we're going to pick it up. Out, in, out. Let's try to pick it up. You go out, in, out, in. 5 more sets, and we'll add a same arm reach. Keep this going. You have 2 more sets. Nice work. And 1 more set, same arm reaches. You go reach out and reach out. So same arm and leg going out to the side. Give me 5 more sets. Keep going. You have 4. Keep it up. Last 3. Nice work. Final 2. Keep staying big. 1 more time each side. Hands to the seat. Hips come forward. Left heel is going to tap front, tap the toes back. So heel and toe. Hopping over something imaginary on the floor like a hurdle and bring it back. Tap it front, bring it back. I really want you to exaggerate it and pull it back. Knee goes up and over as the heel follows. You've got 5 more before we march in place. In 4 and back. You have 3 and back. Final 2. Keep going. 1 more time. We march in place. You march, 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 march for 10, 9, 8, 7. Keep your back tall. Here's 4, 3, 2, and stop. Hands down. Chest lifted. Right leg is going to work now. Heel forward, toe back. Tap heel forward, toe back. Think up and over that hurdle and back. Keep it going. Up and over and back. You got 5 more. Up and over and back. 4 more. Up, over and back. Here's 3. Over, back. Final 2. Over, back. 1 more. We march in place. March, 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 march. You're doing great. Take a deep breath here. Keep marching with me for 5 and 4 and 3 and 2 and stop. Hands to seat. Hips come closer to the edge. You're going to go out with 1 foot, out with the other, in and in. Continue that slow. Out and out, in and in. 1 more time, slow. Out, in, so you can stay at that pace or speed up. Go out, out, in, in. 5 more sets, and we add a same arm reach in 4. Bring it in. Here's your 3. Bring it in. Final 2. And in. 1 more time. We're going to add that reach. Out, out, in, in. This is where it gets tricky. Try to stay with me. Just keep both arms and legs moving and try to power it up with that reach. You've got 3 more sets. Keep going. Final 2. You've got this. 1 more. All right, sit tall, arms down, hips to the edge again. I want you to tap one foot out and reach to the opposite side, okay? Let's do that again. You're gonna tap out and reach and come in. Tap out and reach and come in. Keep it going and back. You need to be closer to the edge of your seat for this. Big tap and reach and back. Tap and reach. 5 more before we switch sides and back. Here's your 4. Come back. You got 3. Pull it down. Last 2 and down. 1 more time. Sit it tall. Take that right leg out. Right arm reaches. And pull it in. Reach out. Pull it in. You're doing great. Reach out and in and out and in. 5 more. Reach. Pull. 4 more. Reach. Pull. Last 3. Reach and pull. Final 2. Reach and pull. 1 more. Reach and sit it nice and tall. Heels go up, down, up, down. Just those heels. Keep that motion and get those arms to go up and up with the heels like you're jumping rope. Keep it going. You got 5 and 4 and 3 and 2 and 1. Now jump those feet. Add those arms. You got 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and stop. You're gonna grab your playground ball or a cushion or a pillow. Come back to the edge. Hold that ball. You're gonna kick and twist to the same side. So let's take that left leg to kick out and twist it left. Here we go. Kick and twist. Kick and twist. Give me 8 more. And 7. You got 6. 5. 4 before we switch to the opposite side. 3. And 2. And now right leg kicks. Twist to the right. Kick it out and twist. Keep going for 8 more. Like you're pushing something away. Keep it up. You've got 5 and 4 and 3, 2 and 1. Sit up nice and tall. Alternate your kicks. Kick out and out. Stay with me. Out and out. In 3 more, we're going to add that ball pressing overhead. In 2, keep it up. 1 more time. Let's press it overhead. Go up and up and up and up. 3 more sets. Keep it up. Final 2. Energy is high. Stay with me 1 more time. Now hold those arms up. Keep your kick for 5 more sets. Arms reaching high and 4. Really kick it out. Kick something. Imagine it's there. Here's 2. You've got this. 1 more time. And now bring that ball out straight in front. Shift your weight forward because I'm going to ask you to run across that finish line. You're holding that ball out. I want you to get those feet going with good control. You're running. Finish line is ahead of you. Keep going. Keep going. You've got 10 and 9. Really speed it up. Get faster and bigger. You have 6 and 5, 4, 3, 2. Arms up. You've crossed the finish line. Great job. Relax the ball down. But just slowly march your feet now so we can bring that heart rate back down. Take a nice deep breath in with me. And exhale down. And again, nice deep breath. And exhale to release. You're going to kick those heels out, alternating just like we started. You've done so much in between. Really good work. You got to keep that energy and that focus, especially when the arms get involved with those legs. Give me 2 more sets. And one more before we take a deep breath in with arms reaching up overhead. Here we go. Take a deep breath in and exhale. One more time. Take a deep breath in and exhale. So why are these cardiovascular exercises important? Well, that's your fit tip, and that's because it improves endurance. And why is endurance important? Well, that gets you to be able to do more things during your day. So keep up your good work, and I'll see you next time. Take care.
Great. We hope you all enjoyed that quick movement break and learned a few new exercises that you can do from the comfort of your home. At this time, we will bring back Dr. Sherman and begin our live Q&A. So again, feel free to continue submitting your questions using the Q&A icon on the bottom black banner of your viewing page. We'll take the next 20 minutes or so to try and get to as many questions as we can. And as a reminder, if we are unable to get to your questions, you can always contact our helpline at 1-800-4PD-INFO. So Dr. Sherman, let's jump right into our questions. We've received a few questions when it comes to freezing. It says, how do we manage the freezing of gait? Freezing is my major symptom. Dopamine is not helping. Any suggestions?
Right. I think that your experience is pretty common. Freezing of gait is a very special symptom, and more dopamine is often not the answer for that. I don't know what has been tried. One thing would be physical therapy and occupational therapy consults to kind of work through some things that might work. One thing that seems to work is some type of cueing. So one thing that we think that happens in freezing is that the brain is getting into a single mode, trying to move the foot, trying to do something, and that way is not working. So that motor pattern is kind of stuck in a rut, and the important thing is to get out of whatever that motor pattern the brain is trying to do and doing something else. And maybe you've tried these things, but singing, marching in place, doing any activity other than trying to move forward can really be helpful. And sometimes it's very individual. What works for one person might not for someone else. So a physical therapist can kind of help work through that and trying to find that. One thing I will mention is that there's some evidence that suggests that medications that increase this brain chemical called acetylcholine can help with freezing. It's even been under study, and the results of that are kind of plus minus, but I think it's worth trying in an individual patient. So these are medications, brand names like Exelon, donepezil, galantamine, rivastigmine. They're medications that are used to help memory, but we're using them in this case to help with freezing of gait. So that might be one thing that if it hasn't been tried, could be tried. And I hope those are helpful. Really, we need more research to understand that.
Great, thank you for that. So we had somebody else write in and say, I'm in the early stages of PD, diagnosed 3 years ago. I'm not on medication. I do have tremors in my hand. I'm an avid exerciser. How can I maintain this so it does not get worse?
Well, I think everything you're doing right now is useful, and one thing you could do is making sure a physical therapy to make sure that you're doing all the right types of exercise, or joining a formal PD exercise class if you want to explore that option. Make sure that you're doing it fully. But it may be time to consider some medications. And if tremor is the only symptom, I will say that can be a little bit tricky, because there are different types of Parkinson's, and some people have a tremor predominant type. And in general, that has a good prognosis, because it means that balance problems and speech problems and memory problems may not be so much in the picture. But the frustrating thing about it is that the tremor itself can be a very difficult symptom to control, and it may take a lot of levodopa. Some medications are thought to be more tremor specific, for example, amantadine. So that in the medication realm might be useful trying. And then I did mention if you're interested in non-medication treatments, one thing helpful for tremor is strength training, we think. So aerobic exercise gets pushed because it's really helpful for the general body, but sometimes exercising the limb to build up the muscles in which the tremor is predominant in can be helpful. Then when you go to do something, you don't have to use as much of your muscle strength. So talk to your trainer about maybe in this case, weightlifting or actually building up those muscles could be helpful.
Great. So speaking of physical therapy services, we just had somebody write in and say, how do you find PT services geared towards Parkinson's? And they are also in Tucson.
And I don't know if maybe Parkinson's Foundation, if you have a resource, that might be the best thing. I don't like to really, recommend particular therapists, even to my patients. I sort of leave it up to them. I do think it's worth a phone call to whatever prospective therapist and just simply ask them, listen, do you see Parkinson's patients? Do you have a therapist that knows about Parkinson's or is interested in that? If you find a therapist, if they know about Parkinson's, it's great. If they don't, they may be able to get training because there is a lot of opportunities for physical therapists to get particular training in this area of PD. And so, if you're in a place where there's not that many to choose from, maybe ask them to get some specific training.
Absolutely. And our helpline is a great resource there. If anyone wants to reach out, they can connect you to physical therapists nearby. And then we will also add a link in the chat where you can find LSVT physical therapists near you. So that is a great place to start. Okay, so next question is, my question is, how do we know what stage of the diagnosis we are in and what does that actually look like?
Right. Well, your physician could probably tell you that. And people ask me that all of the time. It's a common question. And there isn't a simple answer to that, as I was trying to convey a little bit in the slides. The most common sort of scheme for that is called the Hone and Yar classification. And I showed that to you, that there is the 5 different stages of Parkinson's. And they go as follows, stage 1 is when the Parkinson's only affects one side of the body. Stage 2 is when the symptoms start appearing on the opposite side. By the way, which side of the body is totally random. It doesn't matter if you're right or left-handed, and it's not more one than the other. It seems to be really 50-50. But whichever side it starts on, that side always seems to be a little worse with Parkinson's. And eventually symptoms may occur in the other side. That's called stage 2. When symptoms are present on both sides, but balance is okay, it's stage 2. But when balance starts to be affected, that is stage 3. And stage 4 is a little bit like more of the same, and technically it has to do with exactly how bad the balance is. So that's the common scheme that's used. It's a scheme that is used for all the research studies too. But I'll tell you, it has some problems because not everybody's Parkinson's progresses exactly in that way. There are some types of Parkinson's, particularly the types in which tremor is not predominant, that almost start equally on both sides of the body. And then that staging scheme isn't really helpful. So, and in research, we're really trying to find better staging schemes for that. The DAT scan could be one possible way of looking at stages. And there would be different criteria, and that is something physicians can order. But the problem with it, as I'll tell you, is that the way that the FDA insurance sees it is a one-time scan that's only done to confirm the diagnosis. But a lot of my patients, we've been repeating the scans, and certainly for research projects, the DAT scan can be very useful. But there's a problem with the DAT scan too, because even when people are in stage 1 Parkinson's, clinically, they only have tremor on one side. When we get the DAT scan, guess what? There's Parkinson's that's present on both sides of the brain. And that may be that we're detecting something that's important clinically, but or for the future, but it doesn't line up. And the other thing is the DAT scan looks worse very early in Parkinson's, but then it doesn't continue to get worse the same way through the stages of Parkinson's. So there's not a one-to-one correspondence. So we thought there would be, but there clearly isn't. So we really have, there isn't any one good staging system, and this is really an area that research is needed so that we know. It's really important because when we have treatments that do modify the Parkinson's and when they are neuroprotective, how are we going to know it? Right now, we utilize something called the Parkinson's Disease Rating Scale, which is, it gives points for every little thing, finger taps being slow, tremor, hand movements being slow, and it assigns a number of points to each of those. That tends to get worse about 7 points per year. And all of the research is really focusing on that tool. But really, that's not perfect either. It's very subjective.
Great, thank you for that. So we have somebody who wrote in and said, I have what the doctor calls sorry, I lost the question. I have what the doctor called late life onset. What can I expect?
Mm-hmm. Well, sometimes the prognosis is better with onset later in life. It does become more common. I mean, one thing is that if it's taken that long for the Parkinson's to show up, it may be that there's a milder rate of progression. But the treatment horizon is sort of the same almost, whenever it occurs. If people get Parkinson's in their 40s and 50s, they're going to be living with it for a long time. And so, they're going to need to take advantage in their lifetime of some of the more advanced therapies. Someone that develops Parkinson's in their 80s, chances are that medications are going to be enough to carry them through because you live with Parkinson's. It doesn't really have a way of ending life exactly unless there's a fall or something because it doesn't affect the vital organs. So it's something you live with. But if you get it when you're in your 80s, the 10-year treatment is probably going to, get you through most of it or 15 years. And you won't need advanced therapy.
Great, thank you. So we have somebody who wrote in, I know you briefly talked about hallucinations, but they said, does everyone eventually experience hallucinations, illusions, and at what stage?
No, not everyone will be troubled by that. And we don't really know what the percentage of people is. Perhaps maybe a third of people with Parkinson's will end up with illusions and hallucinations. One thing that is important in Parkinson's, most of the illusions and hallucinations occur because of the medicines we use. And to some extent, those can occur even if we use them in people without Parkinson's at a high enough dose. For other conditions, we occasionally use Parkinson's medicines. So it's mostly the medicines, but people with Parkinson's are certainly more susceptible to those side effects of the medications. So not everyone will get that. And in fact, I should point out that by definition, if people develop hallucinations in the absence of being on Parkinson's medicines, in other words, they have hallucinations or illusions, they occur before ever starting a medicine, then the proper diagnosis to consider may be something called Lewy body disease, which is defined as sort of the cognitive and illusions and those sets of symptoms occurring before the movement symptoms, although sometimes they can occur together. It's probably all on the spectrum, but that's the definition, and we're learning more about Lewy body disease, and they may be separate conditions on a continuum and may have different treatments. So that's an important thing to keep in mind.
Great. So we have a few questions about medication. Somebody says, how do I deal with the creepy leg, restless feeling that comes on all at once?
Yeah, so restless leg syndrome is an interesting thing. If by definition, to have restless leg syndrome, RLS, you can't have Parkinson's, but it's a set of symptoms that you're describing, that very uncomfortable feeling in the leg that is sometimes is worse at night. It's relieved by standing up and walking. Those are sort of the definition of RLS. It can commonly occur in Parkinson's, usually in the context of wearing off of medication. So if RLS is severe, maybe the first thing to do is to sort of address the wearing off. Now, dopamine agonists are very useful for RLS. Even if people that don't have Parkinson's, they help with RLS. But with people with both, whether they're related or not, you know, the dopamine agonists can be helpful. Another set of medications that's often used are related to gabapentin and Lyrica. Those aren't used for treating Parkinson's per se, but those are indicated for RLS. So your physician could try RLS medications. So wearing off RLS medications, sometimes exercise can help, but you have to be careful. You think you can wear your legs out and you won't have that feeling, but too much exercise of the wrong type can sometimes worsen it, but the right type of exercise can be helpful.
Excellent, thank you. So I know you had talked about medication and sleep. Somebody said, can carbidopa, levodopa given at night aid in getting to the bathroom?
Well, yes, for sure. You know, and urinary frequency and sleep, that's a whole nother important issue. So if people aren't sleeping through the night, you sort of have to figure out why. You know, if you're having to get up because of frequent urination, sometimes focusing on what's causing the frequent urination, it might just be Parkinson's, but there could be other causes, but getting that under control can be helpful. So identifying what it is that's disrupting the sleep is important. Is it nightmares, REM sleep behavior disorder? Is it overactive bladder? All those have separate treatments, but wearing off is important too. And there are some, for example, there's a very long-acting medication, Rytary, that's a brand name one. I haven't found it to be particularly useful in the daytime, but at night, it's because the peak is unpredictable, it can be useful. But even regular long-lasting carbidopa CR can be helpful, or having a dose at the bedtime. Those things can help with sleep disruption.
Great. So we have a few questions about dystonia. Somebody says, what can one do to address Parkinson's symptoms when they also have levodopa-induced dystonia?
Yeah, that is, that's a really good question. And I would say the specific answer to that really depends on the patient and having a physician sort of sort that out. But in general, I would try to figure out, is it on dystonia or off dystonia? Meaning, is the dystonia occurring in the presence or the absence of levodopa? And you know, it may take, you can sort it out during the cycle during the day, but it might take an examination early in the morning, or even going off the levodopa in the doctor's office to kind of see which set of symptoms is occurring. But that's the first step, because if it's off dystonia, then the usual things that we do to have continuous treatment with levodopa may be helpful. If it's being provoked by levodopa, then we need to know that too, and then it may be the opposite. It may be more frequent doses and reducing and using other medications.
Great. So then we had somebody ask, what are other options for treating dystonia other than Botox?
Well, you know, ultimately, like deep brain stimulation can be useful for dystonia, but that is tricky. You know, occasionally we induce dystonia, but at certain settings. But I would say most of the time it's not true dystonia. It's really we're causing stimulation of some areas that are causing muscle activation, and usually that can be avoided. So, so deep brain stimulation for really severe dystonia can be an option, but really you do have to figure out whether it's levodopa responsive or not. Botox is tricky in Parkinson's. It wouldn't be the first thing I would suggest. I'd look more to the dopamine medications. Anticholinergic medications may play a role. Those are sort of what I call ancillary medications in Parkinson's. But amantadine is an example of a drug that has some anticholinergic properties, and that can be used. Another one is called trihexyphenidyl or artane, cogentin, or benztropine. These aren't mainline Parkinson's treatments, but they can be used, you know, for various things in Parkinson's, including excessive salivation, but they can help with dystonia. So, so trying some of these unusual medications or less often used ones and targeted toward dystonia might be helpful.
Great, thank you. Yes, our next question was going to be, has DBS been used in connection with dystonia? So yes, we just learned that from you. So the next question would be, what are the qualifications for DBS?
Right. Well, I think, first of all, the most important thing is that the Parkinson's disease has to be levodopa responsive. And I think before any center would consider DBS, they're going to want to answer that question. Sometimes we do it in an informal way. Me and my colleagues, we would know our patients well enough to have established that. But a lot of centers require a formal on-off testing. So they want us to do a rating scale, a Parkinson's disease rating scale, off medications for 12 or 24 hours and on medicines, and make sure that there's a big difference. Because that's the first criteria, that the condition be responsive to levodopa. Otherwise, the DBS won't work because it sort of mimics levodopa action, but it does it in a way that that's continuous, and so it does away with the ons and offs. The other consideration is, are the set of symptoms that are impeding lifestyle, are those ones that are going to respond to DBS? In other words, is it motor fluctuations? Is it tremor, stiffness, slowness that are not fully treated by Parkinson's? Are those causing a decrease in activities of daily living? Are those causing the quality of life change? Because otherwise, we might solve that problem. But if it's something else like memory or concentration or depression or some of these non-motor symptoms that don't respond, it might be a technical success, but people might not feel better. Their quality of life might not be improved. So estimating the impact on quality of life is really important for a successful outcome. Otherwise, it might work technically, but people might not be happy because we weren't treating the symptom that was really bothering them. So those are some important considerations in fitting if DBS is the right procedure.
Wonderful, thank you. So I think we'll wrap up with this question, and then it'll also give you an opportunity to talk about some of the research you're doing. Somebody asked if you would give us a synopsis of your study on neuroprotection and disease modification in PD.
Yeah, okay. Well, let me talk about the research. I'll just talk about it sort of informally since we just have a few minutes. I'll talk about our research program right at the moment. We are studying a drug that's been around for a long time that is called ketamine. And this was discovered as an anesthetic drug, and it's been used in anesthesia for many years, particularly in children. But it's a unique molecule, and I think it's been in the news quite a bit. There was a breakthrough with ketamine a few years ago in finding that it could be used in levels that were below what was needed for anesthesia, mostly to treat depression. And that has been really kind of a breakthrough and created a whole industry because it turns out that a one-time treatment with ketamine can treat depression for many months. And that's really different when you think about other treatments for any condition, or particularly depression, where you have to take a drug every day. And it has to do with some very special properties of the drug ketamine and how it can reset the brain. And I won't get a chance to go into it, but our laboratory has really been delving into exactly how does ketamine create this reset. And we've been delving into this in animal models in the laboratory, and we've found that many different levels, we've tried to tease apart what ketamine can do, but it actually creates a new type of learning in the brain. It actually changes the structure of those synapses that I showed a picture of before in a way that restores it back to normal in Parkinson's disease. So sort of modeling after its success in depression and pain conditions where a one-time treatment has this long-term benefit, we have started a research program in which we're giving ketamine as a one-time treatment. We're giving it in 2 5-hour sessions intravenously. So patients do have to come into a center and they need to be hooked up to an IV. And we use a dose of ketamine that we've discovered in the lab that it's not enough to cause anesthesia. People are awake the whole time. They may be feeling, a little sedated and a little strange for that time, but just during the infusion. And after this 10-hour exposure to ketamine, our early research has showed that dyskinesia may be gone for at least 3 months. And we've had a couple cases where dyskinesia seemed to be reset, for a long period of time, for many, many months. So this has been just in phase 1 trials where we know what the subjects are getting. And so in a certain way, we really have to confirm this because we have some biases. I know the patients are getting it. We may have a blinded observer, but we sort of know what's happening, but that's the first step in research. So starting next month is going to be a nationwide phase 2 trial in which patients will be getting either ketamine or an active placebo, a different sedative drug called midazolam. So hopefully they won't be able to tell which they get. And one of the physicians won't be able to tell which they get either. And we're gonna look to see if this holds up and if that ketamine really affects this dyskinesia. But really that's a little bit of the tip of the iceberg because that's our entry point into it. But we think that ketamine treatment, when given repeatedly, may offer some neuroprotections. And what we have our sights set on is eventually using this treatment as a neuroprotective strategy. Now, at the same time, other companies are working on other treatments and new molecules that may offer neuroprotection. But we're repurposing a drug that's already been approved for certain uses. And that allows us to leap forward because there's a whole lot of basic work that doesn't need to be done. It's safe to give people. We have to show that it's safe in the particular way we're going to do it, but we think that we can do that very shortly. Whereas some of the more promising things, they'll be coming along, but they certainly are going to take more years to get to this stage. So I'm really excited about that, and perhaps we'll have a time to sort of delve into that and what our theory is why that ketamine may work. I will just say briefly, it seems to work in experimental animals to slow the progression of Parkinson's. But of course, we have a long way to go to showing that that would work in people.
Great. Thank you so much for sharing that. We love to hear about advances in research and look forward to seeing what's to come. So on that note, that concludes our Q&A session. So thank you so much for taking the time to answer questions from our audience. This was a great way to engage our Parkinson's community here in the Southwest and share information about managing changing symptoms. So again, a huge thank you, Dr. Sherman, for joining us today. I do have a few closing remarks and a couple of slides I would like to share with you all. So just give me 1 second. All right, so to wrap up, we just want to give a huge thank you to our sponsors again, our gold sponsors, AbbVie, Acadia, and Boston Scientific. We are so grateful for your support. We hope you'll come back soon and join us for more of our virtual programs. Next up in PD Health at Home, we have Mindfulness Mondays with a focus on mental well-being. Then you can join us again on Wellness Wednesday for a program focusing on mental health for Parkinson's care partners. Coming up in the Southwest, for those of you in Arizona, we're thrilled to announce that Moving Day is back to being in person. We hope you'll join us on Saturday, November 6th at Kiwanis Park in Tempe. You can learn more and register at movingdayphoenix.org. If we were unable to get to your question today, I encourage you to contact our helpline at 1-800-4PD-INFO, where our Parkinson's specialists would be more than happy to hear from you. Today's session has been recorded and will be available for viewing at our Parkinson's Foundation YouTube channel. As the program concludes, a window will open with a link to complete an evaluation of today's program. We appreciate your feedback and use it to plan future programs. A link will be sent to you in the coming days with the recording, resources we shared in the chat, and the evaluation link if you have not completed it already. On behalf of the Parkinson's Foundation, thank you for joining us today. Stay well and come back soon.